So we are have recordings of our exams and our lectures. And I think we're ready to start checking in. Any questions before we do?
After the exam, you want us back at 4:15?
Yes, 4:15. That should give everyone in the classroom and on campuses to get finished and be back together for our content time. It looks like everybody's downloaded perfectly. I know there was a little bit of panic there, so that's great. If you jump on and start downloading your exam, I say early, but you have access to it 1 hour prior to class time. So I recommend you do that so you don't have a last minute panic attack. No sense in stressing yourself right before an exam. So if there's no other questions, we will get started. Everybody, did you get at least, I know the ones that went to live sessions because I get those attendance rosters, but did you at least get to go back and review the recordings this week? Helpful, you think? We'll know afterwards, right? I'll ask that again afterwards. Okay, take some deep breaths. You've prepared. Relax, read the questions carefully. If you're not sure what it's asking, read it again. Don't panic because it should take you about 38 minutes to take the test is the estimate, but you've got lots longer. So don't panic and rush through your exam. Take plenty of time, read the questions effectively, like a couple times, 3 times if you need to, especially on those questions that are worded oddly. Make sure you know what they're asking. Okay. I'm wishing you the very best. Okay. Aurelia, let's start with you. Okay. I see your ID. Got it? Oh.
That's like my computer setup, and I have my calculator, my glasses, pen, and my paper. I just wrote the time that we're supposed to be back. And then you want a 360, right?
I do.
Okay. And then under here, I don't have anything.
Yes, perfect. And that's good. You are checked in. Thank you. Professor McBride is joining us tonight to help proctor. There she is waving at us. Thank you, Ariel. Alex, you want to go next? Okay. Can I see the bottom of your computer too? Can you just flip it up? Oh, perfect. Thank you. And you need to just have one sheet of paper, not your whole notebook. Thank you. All right, that's great. Shelby Burton. Okay, I see your ID. Thank you. Perfect. Thank you. You have your paper? Okay. So I'm getting there, right? Can you flip your paper over for me? Thank you. Nunu. Okay, thank you.
Sorry. I do
Oh,
this
that's okay.
stupid iPad. Okay. I got a sticker on my thing too.
Okay. Thank you. All right, perfect. Yeah, I've got to note the ones of you that have stickers on the front of your keyboard, so I know I know what it is.
Well,
Thank you.
I just got mine today. I didn't have one last week, but I got it before our exam in med-surg.
Oh, okay. I'll put a note beside your name here from now on, so I'll recognize it when I check you off. Brianna Dixon. There you are. I'm sorry, I couldn't find you. Okay. Okay. I see your ID.
Sorry, I couldn't figure out how to unmute myself. So I just had the time wrote down on the paper.
Okay.
Um,
Okay.
and then that's it. And then my massive dog behind me.
I saw him sleeping back there.
He's
It's cute.
asleep for right this second, so maybe it'll stay that way.
Yeah. Well, if you're muted, he's not going to bother us. Thank you. Julia. Gotcha. Okay. See your paper.
Sorry, give me 1 second. I forgot where to.
There we go.
Where my computer,
Okay.
my desk, and there's nothing behind me.
Okay. All righty. And I checked out your stickers last week or last exam. Stephanie Hickey. Here you are. Okay.
Okay. This is my first time doing this, so please be patient.
That's
I
okay.
think I'll turn my camera around. There we go. Oh, this is my,
Okay.
and then this is my room.
Okay.
I don't know what you're seeing.
Okay. Do you have a piece of paper or a whiteboard?
No, ma'am.
Okay. And I need to see your ID, please.
It's me.
Okay. That is you. Thank you. Valerie Johnson.
Yes, ma'am. I got my ID.
Okay. I see it. I like your green wall behind you. That's pretty.
Oh, it's my green screen to back out it's the kids gaming thing, so I just closed the room off. Here's my calculator.
Okay.
Here's my white sheet of paper.
Okay.
And here is, this is my.
Oh, I see what you've got behind you. I thought it was just a green wall. Okay.
And then here's my computer. In front of me, desk area.
Okay. All right. Thank you.
You're welcome, honey.
Cheryl.
Oh my God, I didn't know I was unmuted the whole time.
Oh, we
Okay,
weren't hearing you.
my dog, she's panting. Okay,
Oh.
here's my ID.
Okay.
Here's my computer.
Okay.
And I do have stickers. I don't know if you caught that last time.
Yeah.
One there and there. Okay.
Okay.
And there's underneath.
Okay.
Can you see my paper?
I can. Just flip it over, please.
Okay.
Okay. Thank you.
All right. And I don't know if I need my glasses or not. I usually wear them, but I'm blurred. So
Okay.
can I
Okay.
just keep them off and then put them on if I
Yeah.
need them?
Yeah. Can I see your glasses though?
Yeah, absolutely.
I don't know if I have a note that you're wearing glasses or not.
Well, I always wear glasses, but today I just they're blurry when I wear them. So,
Okay.
and here's my room. I'll just do a little
Okay.
loop-de-loop for you.
Okay.
There's my big dog.
Did you tell me day one that you wore glasses? I think I got
Yes.
it. The
Yes,
note
I
that you
do.
did.
I wear
Okay.
glasses. And if you want me to put them on, I'll put them on.
It's okay. I just noted the students who do wear glasses, so I would know
Yes. Yes.
on week one. Okay.
Yes.
Thank you.
Thank you.
You're good. Thanks. Heather. Mhm.
Let's see. It's my computer.
Okay.
I have a calculator and a blank paper
Okay.
in the kitchen.
Your work area. And you've got a puppy sleeping in the floor too. I tell you. How would you do nursing school without your puppies?
Support dogs. Will you meet me, please? I'm having trouble. Cheryl.
Okay. You're done. Okay. And I'm sorry, Heather, can I see your ID one more time? I missed it. Perfect. Thank you. Okay, Maggie. I got your ID. Thank you. Got your paper. Can I see the bottom of your computer, please? Just flip it up. There you go. Great. Thank you. Courtney. Are you sitting outside in Florida? I'm jealous. Okay. I see your ID. Thank you. Okay. Do you have paper? Okay. Perfect. You're good. Thank you. Stephanie Robinson. Okay. Do your ID.
My room,
Okay.
my computer,
Okay.
print,
Underneath. Okay.
and my paper.
Okay. Perfect. Thank you.
You're welcome.
Kimberly Rubio.
Hello.
There you
My
are. I see your ID.
Let's see if I can turn this around. Sorry.
Okay. That's okay.
There we go. Paper,
Okay.
laptop.
Okay.
There we go. And then I also have a dog sleeping.
Okay. Thank you, Kim.
Uh-huh.
Shelby Wyland. Okay, I see your ID. Mhm. I got it. You're good.
I also have a sleeping dog next to me.
Does anybody not have a dog? Just two? Three. Okay. Okay. I'm sorry, Shelby. Can I see your workspace one more time?
That's fine.
I was distracted. You started the dog thing there again. So
Okay. That just says what time to come back. My stickers, which were there last time,
yes. Okay.
and
I got
then
the note
my
here.
drink and whatnot.
Okay. All right. Thank you. Kyrian Williams. There. Okay. I see it. I see your ID. Thank you.
My internet
Okay. Good.
is- So let me know if it goes out at all.
Okay. And just
And then-
lift up your laptop. Perfect. Thank you, Kyrian. And Michael, we're going to have to start at the other end so you're not last every time. I got your ID. Thank you. Okay. Okay. Did you have a calculator laying there too? Okay. All right. I think we are all checked in. Any questions before I give you the code and we get started? We're going to return at 4:15. That way our people on campus will have time to get back in class.
Hey, I changed my mind. Can I put a little sticky note, just a plain sticky note on my computer just in case I need it for math? I didn't even think about math earlier. I'm so sorry.
Oh, you don't have a piece of paper?
No. Can I just
Okay.
put a regular sticky note?
Yes.
I'll show you.
Just hold it up and let me see. Okay.
All right. Thank you.
Okay, I'm going to read off the password to you. And then I will put it in the chat. So everyone needs to be muted. If you have any questions, any issues, let me know. We'll go to a breakout room. Okay, so we're not interrupting anyone in the class. Are we ready? Okay. Best wishes. Take a deep breath. You got this. You've been working hard this week. Capital W. Capital U. Lowercase g. The number 7. Capital Y. Capital V as in Victor. Lowercase f. Lowercase a. Capital P. Lowercase h. Capital X. Capital M. I will put it in chat. Best wishes.
by one by one, or just so you can sort of bracing for the bending of the bedboard. And I don't know exactly what you need, but it's kind of measure it out. You need to go down all the way down to both sides and across the top, and you should be good.
I'm really jealous you people sitting outside in the sun, I have to say. Aren't we, Maggie? You look jealous too. Okay, I need everybody to turn their cameras back on so we can get started. Okay, I think Heather's the only one I can't see. There, I see you now. Those of you who tested on campus, see if I see Michaela. Who else tested on campus? Kayla, you're there. That all go okay?
Miss Cassandra, are you at least able to tell us if we passed or failed?
I don't have the scores yet. No. Nope. All I can see is that your exam was uploaded. Nunu, I think you were one. I had 3 that left without showing me their green screen. So I need to see your green screen when you're complete. And then I check to see that your exam uploaded correctly. And I do know that everyone's exam did upload. I went in and checked, but that's one of the things that I need to see that green screen. And then when you show me that, I look to see that it's uploaded. And then that's when I tell you you're good to go. So if you don't show it to me, I can't be sure that your exam has been uploaded to ExamSoft there, because there have been glitches that have happened and a student may not have gotten credit for their exam. So you don't want that to be you. So be sure you show me that green screen so I know that you're finished, and then I can check that it's uploaded, because by the time that we complete our class, the deadline's passed, so you can't upload your exam any longer. So we need to make sure that there's a reason behind our madness. So be sure you show us that. just some kind of housekeeping stuff before we get started on content tonight. Starting next term, do any of you have an online class next term? Some. There will be new guidelines for online exams. You won't be able to use a piece of paper for your math. You will have to have a whiteboard, or you'll be able to use like a plastic sleeve with a piece of paper inside the plastic sleeve and write on it with a marker. And then at the end of the exam, you'll show us your green screen, wipe your board, and then we'll tell you you're good to go. Okay. So hello, friend. So I'd like to try that next exam if you have a whiteboard, just so you'll be ready. And when your first exam comes next term in your online class, you won't be concerned about how it works. You'll be like, oh yeah, we did that last term, so we're all good. I know one course, that's the only way the instructor does the math problems in her class. So that class is already doing it. I know that every community in the nation has a Dollar Tree. They're $1.25 at the Dollar Tree. So cheaper than a package of paper or a notebook. So I would run in and grab me a whiteboard and a little marker, and you'll be good to go for next term. And we can try it on exam 3. So you guys will be ready. What's next Monday?
I keep forgetting I'm muted.
No class.
Memorial Day.
Day.
Yes,
Memorial Day.
yes. Memorial Day, which means it's no class Monday, right? Yeah. You will not have class. That's why you've been spending an extra 15 minutes with me each week. And so your class has been a little bit longer than everyone else's, and you will not have class next Monday. All of your resources for next week's content will be online. You'll have access to everything. If you have any questions, I will be available all week. But be sure you jump in there and don't ignore the content from next week. Your PowerPoint will be posted. If you have questions over any of it, reach out to me. I'll be happy to answer your questions, but we will not be having class. So that'll be nice. Enjoy your Memorial Day weekend. Then I wanted to look at our syllabus. Do most of you print it off and have it accessible? Yes, no, just look at it online.
I have mine accessible, but it's not in the room I'm in.
Oh, that's okay.
But I print them at the beginning of the term, so that way when we go over it, I can write down what I need on NCLEX and what I need on CJ Sims.
Yeah. It always worked for me, even in online classes. If I was taking an online class or I'm teaching an online class, I like to have a paper copy, and it makes me feel really good when I've completed something that I can mark it out or highlight it. It makes me feel accomplished, I think. But it also keeps me on track. And I know a lot of students or faculty for that matter, would say, I put appointments in my phone, and that keeps me on track, or I use the calendar in my phone. And then they proceed to miss appointments, not show up for things, not turn in assignments. It's like, how's that working for you? So I still suggest that you print it out and have it close at hand. I actually, a lot of times, tuck my little syllabus inside my laptop, close the lid, and it's right there. So that's the first thing I see when I open the laptop. It's right there in my face. Maybe annoying sometimes, but it's still there, and it keeps me from missing assignments or turning things in late. So this week, you guys have a lot going on. You've got that exam behind you, which is a good thing. You can take a deep breath. Did you feel like you were prepared for exam 2?
Kinda. I felt pretty good, but
Yeah.
Are you able to tell us if we passed or failed, like privately? Not the percentage, just if we passed or failed.
Yeah, I won't have any idea for a little while, probably not till tomorrow.
Okay.
And then I can look at it and I can tell you if you
Individually?
yes, I can tell you individually. If you reach out to me, I can say that you achieved a 78% or not. I can tell you that.
Okay. Expect a lot of emails.
We'll take that.
Yeah, you message me and I will tell you that after I can see the score.
What, 8 a.m. work?
But you know, that's do what?
8 a.m. work when I get off work?
Yeah, and it'll be when I have a chance to look at them. I have an appointment out of town in the morning, so like I will be gone all day tomorrow. If I have access to it in the morning, I will do it first thing. The thing is, those scores may change because when we do the item analysis at the end of the week on Friday night, if we give credit for anything, like give A and C instead of just A, those scores may change.
So
Okay,
that
so it may not be
down.
it should not go down, it should go up.
Then I don't care. I just want to know if I pass.
Okay.
That's it.
So if anything, your score should be better than what we think it is today.
I feel good about it, but that also makes me feel a little nervous that I feel good about it. So
That's okay. Feel confident. You studied hard. Feel confident.
I think it was the first time I don't know. And then this time I was like, let me find, I do well with videos, like seeing and visualizing. And I looked up videos and was able to.
That's
Cross-
very good. If there's content that you're struggling with, YouTube has some really good videos out there. Now just be careful which ones you're looking at, you know, that it's not giving you bad information. Make sure you're looking at some evidence-based videos, that it's not just somebody off the street making something. I would review the content that Fortis puts out first, and then if it's anything contradictory to what you're seeing through school or from your textbook, then I would question that. But visual things are the way I learn as well. So I like video, and just hearing it is so much better for me than reading it. So this week you are going to have another discussion due, and your teaching plan is due this week. Be sure that you read the criteria for that teaching plan. Make sure that you have all your resources cited, and that when it talks about doing a fetal assessment, that you're not just identifying the anomalies, but you're identifying all of the things that are normal as well. Do that full assessment of a normal baby, and then identify what's abnormal, because that's part of the criteria. Okay, so if you don't say all these things are normal, then you're missing points on the rubric. Okay, so be sure that you look at the rubric that you're going to be graded on as you develop that teaching plan. So this week is kind of a lot of work, but you'll be good. You got all that studying for the exam behind you there. Questions?
Yeah, I actually had a question for
Okay.
week 8. It's got a quiz on there.
Uh-huh.
So how are we just taking that without video, or
On
that's next Monday?
we will take that the following week when you have an exam. After we do the exam, you'll take your quiz.
Okay.
So for you guys, it's kind of good because you're going to be studying all that information for the exam, and it'll be the same information that you would study for your quiz too. So you'll kind of miss that quiz, but it's still going to be the same content that you would study for the exam. So kind of 2 in 1 day.
Okay.
Yep. So it will be, we'll do the exam first. Once we come back, then we'll do the quiz. Okay, good question. All right. Anything else before we start talking about content tonight? Okay, I'm going to share the PowerPoint. Okay. Can you guys see my PowerPoint? Yeah. Okay, we're going to talk more about newborn care tonight. I'm gonna set the timer because we don't have a whole lot of time and I don't want to keep you. Okay. Okay, so the neonatal period is the first 28 days of life. So from birth to 28 days old, you can think of it as just their first month is considered the neonatal period. And tonight we're going to talk about some of the changes that happen immediately after birth. The transition to extrauterine life is pretty amazing how the baby is designed to survive inside, and then that transition to life outside the uterus is an amazing transition. We expect it to be essentially complete in the first 6 to 8 hours after delivery, but there are things that parts of the transition that are continuing to take place, but we want the baby to be nice and stable within the first 6 to 8 hours. You're going to see, we talk about 3 stages of newborn transition, and the first period is up to the first 30 minutes. And in that first 30 minutes, the baby's heart rate increases, and then it decreases back to around 120 beats per minute. But we know that a baby can be 120 to 140 beats, right? Or 160. So we're going to expect them to be somewhere in that range. 120, 140 beats is going to be what we're going to expect after the first hour-ish of delivery. Their respiratory rate is much higher than adults. So we're going to talk a little bit more about the specifics of that later on. Right after delivery, we might hear some crackles from some fluid being in their lungs, and that's normal immediately after delivery, but we want to watch that and make sure that it clears. We're going to talk about grunting and nasal flaring and retractions and what that means, how important it is. If you see that initially at birth, we're going to watch it, but it should clear within that first 30 minutes and make sure that they're breathing normally in the first few hours after delivery. So a baby who may be grunting or have nasal flaring at birth probably is going to go to the nursery for observation rather than being left with mom. If it does that for the first 2 or 3 minutes after delivery and then it clears, then they may go ahead and leave it with the mother. But if it does it for an extended period of time, they'll take it to the nursery and watch it. They're going to listen for audible bowel sounds. Babies will or should pass meconium soon after birth. What's meconium look like?
Green.
It's like greenish black.
They're what we call terminal meconium, and which is that first meconium is black. It's sticky. It's like tar. It's hard to get off of them, and that's perfectly normal. And then after that, it turns a little bit greenish yellow, and then it turns to normal stools. So a normal stool of a breastfed baby looks like what?
It's like yellow.
It's like yellow and grainy, like
yellow and seedy, isn't it? Yeah, watery. Yeah. When's the perfect time to start breastfeeding? We talked about that before.
1 to 2 hours after birth.
Yeah, early, right after delivery, right in the first few minutes. Because when we talk about this period of decreased responsiveness, this says 60 to 100 minutes. It's the first couple hours that you've got a baby that's pretty wide awake after being delivered, coming into this old cold world and it all wet and mad. After that, it gets sleepy and you have that period of decreased responsiveness. And if it hasn't eaten before that, then it's probably not going to nurse well. So we want to catch it early and before this period of decreased responsiveness hits. So we want to catch them in that first couple hours for sure. We want our babies to be pink for sure. And we're going to talk about what they're going to look like here in a little while. We want the respirations to be unlabored, shallow respirations or rapid respirations. Either one can be abnormal. Babies can breathe up to 60 breaths a minute. Above 60 is abnormal, but you will see babies that will have periods of rapid breathing, and then it will go back to a normal pattern. Those of you who have babies, do you remember them going and then kind of holding their breath and then going back to a normal pattern of breathing and it's scaring you? Anybody remember that? Yeah, it's scary, isn't it? You're thinking something's wrong with my baby. And that's kind of a normal occurrence with newborns. They do that. As long as they don't hold their breath for more than 20 seconds. And 20 seconds when you're watching is a really long time. And when we think about 60 breaths per minute, that's really fast compared to an adult's breathing. But if they are 62 or 64, it's still okay. That's if normal is up to 60, and they will have a period of respiration or of breathing that is 60, 62, 64, and then it goes back to a normal breathing pattern that's lower. That's still okay. That's not something that we're going to worry about. Normal fluctuations in newborn respirations. The second period of what we call reactivity after a baby's born runs like 2 to 8 hours. And that's a period that you may see some tachycardia and some tachypnea. So fast heart rate, fast breathing. You have increase in muscle tone. So the babies are moving around more. They're using their muscles more. They're kicking and they're stretching. And that's good. That's what we want to see. You see changes in the skin color as they're breathing better. That skin is pinking up. So we like to see that. Sometimes there's mucus production that you notice. They're spitting that out. And meconium. You're going to see them start passing meconium in the second period of reactivity. Preterm babies may not follow this transition just due to immunity or immaturity. They may be outliers. This stuff may happen much more slowly, and they can really be far outside the normal ranges on any of this being preterm, depending on how preterm they are. Okay, so talking about the respiratory system in particular, the initiation of breathing, making that transition from the breathing movements that they have internally, where they're not actually breathing air into their lungs, but the lungs are expanding and they take fluid in, but they're not taking air in. So as the respiratory system is transitioning, you have some different components that help the baby transition to extrauterine life. And some of those factors that we consider are chemical factors. And that's when O2 and CO2 in the blood during labor help prepare the baby to breathe on its own after delivery. Release of catecholamines in the fetus during labor is also a chemical factor in preparing for extrauterine life. Mechanical factors, which is just the change in intrathoracic pressure, which is the squeezing of the baby when it's delivered vaginally, and less so when it's delivered by C-section. helps prepare the baby for breathing. And and also clearing mucus and secretions when they're screaming. That helps clear that all out, and they're going to breathe better. And then you have thermal factors, which is they have a drop in temperature. They're nice and warm and snuggly inside, and then when they come out, obviously our I don't know what that is. Our temperature in our room temperature is much cooler than what mom's body temperature is. So that also helps the baby transition. The lungs are established, gas changes established when, or starts to be established when we clamp the cord, and that causes a rise in the blood pressure and starts the transition in vessels in the body. We're going to look at a visual here in just a minute that's going to show us what changes. We talked about apnea up to 20 seconds, followed by periods of rapid breathing, which is called compensatory breathing. So when they hold their breath and then they breathe really, really fast, it's compensating for that period of apnea. And we're going to talk about abdominal breathing here in a little bit too. Okay. Signs of respiratory distress. Nasal flaring, when the baby's nose kind of opens up and it looks like it's breathing through its nose, but that nasal flaring is a sign that it may be having some difficulty breathing. We don't like to see babies breathing through their nose like that. So nasal flaring is a sign of respiratory distress. Intercostal, or what they call subcostal retractions. When these are things that when we were talking about looking at videos, these are things that you can look up YouTube videos and see really good videos of what intercostal retractions look like, substernal retractions, what stridor or gasping looks like. So I would look those up so you know what they look like. Grunting with respirations. Typically grunting happens on expiration. So you'll have a baby that every time he breathes out, he makes this little grunting sound. And what it will kind of sound like a sigh. You'll hear him go. So sometimes it's very rhythmical, and sometimes it's not with every expiration. It will just be occasional. But when you hear that grunting sound with expiration, that's not normal. That's also a sign of respiratory distress. So that's something that we're going to monitor probably in the nursery. We're not going to leave the baby with mom if they're grunting. Seesaw respirations. That's something where the respirations, if we're monitoring them, are going up and down and up and down and up and down. So just like sawtooth. Changes in color. We're monitoring, and we want a change in color. We want it to go from bluish gray to nice and pink overall after delivery. Now, acrocyanosis is normal for the first 24 hours. What's acrocyanosis?
Like a bluish.
Bluish where?
On the hands and feet.
Yeah, the hands and feet and extremities, you want them to be centrally pink, but the hands and feet are often kind of a bluish gray color. Those are the last things to pink up on a baby, and it is considered normal for the first 24 hours. And we're going to talk about APGAR scores in a little while. If you have an APGAR score of 910, they probably lose a point for their hands and feet being gray or blue, because that is the last thing to pink up. So if you have a 910 APGAR, you can almost bet always that 1 point's taken off because of acrocyanosis. Their trunk's nice and pink, but their hands or feet are blue. Again, respiratory rate Less than 30 is not really good, and greater than 60 is not really good. What's a normal respiratory rate for an adult?
60 or 12 to 820. 12 to 20.
Okay. So we need to keep in mind that a newborn is very different, isn't it? An adult respiratory rate would be a very sick newborn. Okay, so be sure that you remember what the normal should be for a newborn. And again, what happens if they have that tachypnea and they're breathing really fast, and they're breathing like 66 breaths per minute? Are you going to be concerned about that?
What was your question?
If the baby's breathing 66 breaths per minute, are you going to get concerned about that?
Yes.
What if it's breathing 66 breaths per minute and then you wait a minute and you take it and it's breathing 52?
Yeah.
No.
That'd be okay, wouldn't it? Because 30 to 60 is normal. And we know that babies have those periods of apnea and then periods of tachypnea. So as long as it's not sustained tachypnea, it's okay. It's okay. It's not a trick question. If you have a baby who's sustained, respirations are above 60, you know, they're saying 78, 68, 78, 82. Every time you take it, that's a problem. Okay. But you just assess their breathing or their respirations once and it's barely above the 60. That's not a problem because they will do that. That compensatory reaction to that apnea that happens, and being a little over that baseline is perfectly normal. Now, if they're continuing to do it, that's a problem. But like if you get a question, read into the question. Is it continuing to stay up, or is it a one-time assessment that's above that normal? Okay. Okay, here's a little chart that talks about what babies look like. And this is where I would look at some of these things on YouTube videos just to see what it looks like in an actual baby, what chest movement should look like, what intercostal retractions look like. You can see the muscles between the ribs pulling down when the baby tries to breathe. Xiphoid retractions. Where's the xiphoid process? Yep, you're right, Courtney. Right there at the base of the sternum. And you'll see retractions around the xiphoid process. Clavicular retractions, you'll see them up here around the clavicles. So you can see those muscles pulling when the baby tries to breathe, and that's not normal breathing. You can see grunting. You can hear grunting when the baby's trying to breathe too. So look up some videos of that as well. There's an acronym to help us assess a baby, and it's called wet frog. The W stands for wheezing or high-pitched airway sounds. And you can hear that without a stethoscope even. Sometimes if you're listening to a baby breathe, you can hear that whistly sound. And definitely if you're listening with a stethoscope, you can hear that wheezy sound with a baby. Effort. This is where we're looking for the retractions, inward movement of the supraclavicular fossa, or those down here, we're talking about retractions, the intercostal retractions. So we're looking at what kind of effort this baby's having to put forth to breathe. Tachypnea, greater than 60 beats per or breaths per minute. And again, is it sustained or is it just a one-time assessment of that? F in the frog is flaring nostrils, flaring nares. We spoke about retractions. Oxygenation. When we determine oxygenation, we often put a pulse oximeter on the baby's finger, hand, wrist, foot. Depends on where you're at, what kind of device they have to put on the baby. Often it looks like a Band-Aid that we put on them. It's attached to a pulse oximeter cord. Monitors the oxygenation in the baby's blood. But we can also tell if you just go to a patient's room and you have a baby that's respirations are a little fast, you undress them and you just look at them, watch them breathe, and they're retracting a little bit. You're looking at their color, and they may be centrally pink and their hands and feet are still kind of blue-gray. Look at their lips. You know, that's a good indicator of oxygenation too. Are their lips kind of blue-gray? We're getting worried about this baby if that's the case. And grunting, expiratory grunting. We might whisk this baby off to the nursery if we're seeing some of those signs that are not normal. Okay, questions about that stuff so far?
No, ma'am.
Okay. Think you kind of know what a normal baby should look like? Kind of. The things that happen right at delivery, the first few hours after delivery, changes the baby changes from fetal circulation to extrauterine circulation. And there are some shunts that if you've been reading ahead, and I know that that's a lot to expect on a day that there's an exam. The next slide here shows a good picture, and there's a picture in your book that might even be more clear. And you've got the ductus venosa down here by the liver. You've got the ductus arteriosus up here, shunting blood to the lungs, and the foramen ovale here in the heart. So we're gonna backtrack up. Okay, so the fetal shunts that are open in the baby during fetal circulation are the foramen ovale, and that shunt goes between the atria, and it shunts blood from one atria to the other. It doesn't have to go to the ventricles and that way go to the lungs, because the baby's not breathing air in to the lungs to go for the blood to go to the lungs to be oxygenated. So that shunt moving between the atria is perfect for fetal circulation. Then you have the ductus venosus, and that bypasses the liver. It carries oxygenated blood from the umbilical vein to the inferior vena cava, and that is converted to a ligament around 2 to 3 months of age, post-delivery. There are times when that does not close off. So there are circumstances where they might have to go in and close that, or they may just monitor it and it may close at 6 months instead of 3 months. So there are babies that they monitor that ductus venosus to make sure that it closes appropriately. And then the ductus arteriosus. This is the one that bypasses the lungs, and it starts closing in the first 24 hours after delivery. Again, this is an opening that's very important during fetal circulation, but has the potential to not close off after delivery. So if you have a baby that has, they may detect a murmur at birth, and it just be the ductus arteriosus that they're hearing. And they'll say, you know, we hear a murmur, but we're going to watch this baby. So at 24 hours, they're going to still be listening. They may not hear the murmur anymore as it starts to close. Pediatrician's going to note that when they bring the baby back to the pediatrician's office in a week. They're going to listen for that murmur again. If they're still hearing it, they're going to follow up. They watch those babies very closely. So they're going to follow up and make sure that that murmur goes away. Again, the ductus arteriosus, that opening between those areas, closes off and creates a ligament, and they're going to monitor that to make sure that it does close. And if it doesn't, they can go in and close that surgically. But quite often, if it doesn't close off within the first 24, 48 hours, it may close off in 3 or 4 days. So it's something that they typically just monitor in a baby. But if they know that it hasn't closed, they can surgically close it. All of this starts to happen once the baby's delivered and the cord is clamped. So that takes us to the umbilical cord. Any questions about the shunts, the fetal shunts that change once the baby's delivered, that moves us from fetal circulation to extrauterine circulation? For exam 3, and probably your quiz, which that'll be one and the same for you guys, I would know what each shunt does, where it's located, what it transverses, like between the atria or, one area to the other, and when it should normally close. I think those are probably the things that you would need to know for exam purposes. Questions? Okay.
No, ma'am.
Okay. Our cord, it should typically have 2 umbilical arteries and 1 vein. What do you know about the umbilical arteries and veins that make them unique? What kind of blood flows through your arteries?
Oxygenated.
Right. And opposite. In fetal development, it's the opposite. So in the cord, the umbilical arteries carry unoxygenated blood, and in the umbilical vein, it carries oxygenated blood. So the way you remember it is just the opposite of what flows through your body. Okay. Okay. Again, the heart rate is 120 to 160, which is normal. And we typically on a baby, we assess an apical pulse. So we're listening right over the heart, and we listen for a full minute. And why do you think we're listening for a full minute? Rather than, like, often on an adult, we'll listen for 30 seconds and double it, or 15 and times it by 4.
Because it's usually not it's super fast, so it like can vary up or down. It's never like the same thing all throughout.
Yeah, it is super fast, but one of the big reasons is we're listening for a murmur too. And if you just listen for 15 seconds, do you think you're going to miss those? Yeah, if you just listen for 15 seconds on occasion, if there's a murmur there, you're very likely to miss it. I like to listen to my babies for a while, so I usually listen much longer than a minute. I think of every baby as my baby or my grandchild, and if there's something that's concerning me about that baby, or just listening to a regular healthy baby. I listen to it for a while. I will put the stethoscope on their chest and I will count my heart rate. And if I'm assessing them, I'll just keep that stethoscope laying there and I will look at the baby. I may move their arms and legs around, whatever I'm doing, and I'm still just listening to them. Whether I'm listening to respirations or I'm listening to their heart rate, just so if there's something abnormal that I may hear it, even if it's by accident. Because if it were my baby, I would want somebody to take that extra step or that extra couple minutes that might catch something that would be concerning. Where we listen is fourth intercostal space, midclavicular line. That's important. That's something that your exams like to ask, where are you going to listen to assess the apical pulse. Let's see. Oh, in murmurs, when we talk about murmurs in newborns, they're considered non-pathological up to about 6 months. And that's the time period that pediatricians, they'll keep having a baby come back and they'll be watching to make sure that what they're hearing does go away. Okay, that should be the period of time that those shunts close off completely, and you should no longer hear any kind of murmur. And after that 6-month period, if they're still hearing something, then they may refer to a cardiologist, like a pediatric cardiologist. Okay, let's look at a couple questions here.
Just real quick.
Yes.
Why is it the apical pulse measured at the fourth intercostal space instead of like an adult where it's at the fifth? It's just be like size?
Yeah, just the proportion of the baby.
Okay.
Yeah. And as it grows, that's going to change. So. Okay, I should have you some questions about respiratory. So. Okay, you can't see my screen now, right? I mean, you just see the PowerPoint?
Yes, just the PowerPoint.
Okay. Okay, a nurse is assessing a newborn who is 2 hours post-delivery. The infant is exhibiting nasal flaring, grunting, intercostal retractions, and a respiratory rate of 76 breaths per minute. Which of the following actions should the nurse take first? A is suction the infant's mouth and nose using a bulb syringe. B, notify the healthcare provider of your findings. C, oxygenate via a hood, oxygen therapy. D is place the infant in a sideline position to promote drainage.
Suction, A.
Very good. Yeah, we would suction the infant's nose and mouth. What's the most common reason for poor oxygenation in a newborn?
Stuffy nose.
Not being able to clear the airway. So could be stuffy nose, could be mucus in the nose, mucus caught in the throat. But the first thing we're going to do is try to clear that airway. And Courtney always wants to call the doctor, don't you? She likes to do that. So and I was talking to another student the other day that we were talking about calling the doctor. When you call a doctor, what happens even if it's urgent? How quickly do you get to talk to them?
Up to 10 minutes.
Yeah, if that's on a good day. So we really need to do something. If it's oxygenation issues, we need to do something. Bleeding and oxygenation, right? We need to try to intervene. So if we suction this baby and we're not getting anything out, and we may try to apply some like apply oxygen, and then we call the doctor would be appropriate. But we want to intervene first, because calling the doctor or notifying the provider of our findings, it's going to be a while before they're going to respond, even in an urgent situation. So we need to intervene. Okay. Let's see if I can find. Okay, a nurse is assessing a newborn who's 1 hour old. The following findings require immediate intervention. A respiratory rate of 64 breaths per minute is A. B is nasal flaring and grunting. C is irregular breathing pattern. D is brief periods of apnea lasting less than 15 seconds.
Nasal flaring and grunting.
Perfect. Nasal flaring and grunting, B, right? Because respiratory rate of 64, unless that's continued, that's not a problem, right? Nasal flaring and grunting is a concern. Irregular breathing patterns, we talked about how that's not uncommon with newborns. And periods of apnea up to 20 seconds is normal, so very good. A newborn is 2 hours old, showing signs of respiratory distress, including cyanosis, intercostal retractions, and grunting. What is the priority action? Place the infant in a prone position. Increase the room temperature to reduce cold stress. Initiate oxygen therapy. Feed the infant to improve energy and oxygenation.
What was C again?
Initiate oxygen therapy.
C.
C.
It would be C. Yeah, initiate oxygen therapy. Placing the baby in a prone position, usually in the hospital setting, is not ever going to really be your answer. Increasing the room temperature to reduce cold stress. We want the baby to be in a warm room, but that's really not going to help in this situation with respiratory distress. Oxygen therapy should help if we have retractions and cyanosis. Doesn't say, it says it's grunting, but it doesn't say anything about anything that looks like airway obstruction other than the grunting. So oxygen therapy looks like a good choice. And we would not feed a baby that was having respiratory distress. That's not a good idea. So
How much oxygen?
We would start out with 3 or 4 liters, and it would just depend on what's going on. And there's different ways to administer oxygen to a newborn. Like in one of the earlier questions, it talked about administering through a hood, and that is where you just, the airflow is coming into a little plastic hood, and you put it over top of the baby's head, and the oxygen just flows in around the baby. What we do a lot of times for a baby like this that's grunting is we call it blow by, and we just hold a little tube that has oxygenated air coming out of it, hold it in front of the baby's face. And we might even put it between our fingers and hold our hands kind of over the baby's face. So it's not like a mask, but it's still fairly concentrated oxygen blowing by the baby's face. Or then we can use a mask and put it over the baby's face, and that is highly concentrated oxygen that the baby's breathing. So depending on the extent of what the baby looks like, how we're administering the oxygen, and then you have standing protocols as to what you set the oxygen level at. You can cause eye damage from administering oxygen at too high of a level on a newborn. So you never want to exceed the recommended oxygen concentration. And neonatal resuscitation has guidelines for all of that. It will give you guidelines for all ways of administering oxygen to a newborn. Okay, which of the following newborns is at highest risk for developing respiratory distress syndrome? A term infant delivered by vaginal delivery, a preterm infant born at 32 weeks gestation, an infant of a mother with a history of hypertension, or a post-term infant born at 41 weeks?
B, preterm.
A preterm infant, because their lungs are not developed well, right? Yeah. What do we do to help develop their lungs?
The meth shot.
Betamethasone, yes. And how does it work? This is review from last week.
It increases surfactant in the alveoli.
Yes, it causes the baby to produce surfactant. Yeah. Absolutely, very good. Was that on your test? No, you knew it and it wasn't on your test?
There was
Well,
one
that-
question that had the methyl. I can't even pronounce it correctly, but there was one question that had it in there.
Yes,
Okay.
it was.
Yeah.
Okay. Well, good.
I think it was maybe what to I blacked them out after I take the exams, but it was like something about what do you assess?
Okay.
I can't remember the exact question.
Okay. Well, if it, the stuff that you know, you want on to be on the exam for sure. Okay. Any questions about babies with respiratory distress? Okay. There's a lot more content for this week that we really haven't had time to cover. I will post your PowerPoint for this week, and there will be, like, your full-time instructors will continue to have additional learning opportunities. They will still be having their additional sessions throughout the week, so jump in. Those are great opportunities for you. The live sessions give you the opportunity to ask questions, so that's really good. I have a question here. Okay, anyone have questions for me before we finish for tonight?
I do have a question, but it's in regarding to the teaching plan.
Okay.
So I was reading it and it says that we need to find a so we need to focus in the abnormal findings. Do we just choose 2 of those abnormal findings and then the
Yeah.
rest be normal for the head to toe, or do
Yes.
okay.
You just choose 2 abnormal findings, but just what I was talking about, the normal, just be sure that you document all of these things are normal, because last term students were not documenting anything as being normal. They were just saying, hey, I assessed this newborn and these were my 2 abnormal findings. And you, in order to get full credit, you have to say all of these things were normal. So when you do your assessment information, identify what normal findings would be.
Okay,
I
so
want
basically
you to
do
get
like
there.
a head, lungs, cardiac, and like what we usually do, just like
Yeah.
state premature infant is not able to feed correctly,
Mhm.
and so on and so forth. Okay.
Yeah, your book has it laid out, like a full assessment laid out very clearly, and assess all of those things that are normal and identify that. So, you know, it's not anything tricky. It's just, I think people got caught up on the fact that, oh, I'm supposed to identify 2 things that are abnormal. And they did that, but then they didn't say, but all these things are normal, you know? And so look at your rubric even before you start. Okay. And if you have questions, holler at me. I will be on the road all day tomorrow. And then I'll be checking your scores to see that you hit 78 or you didn't. And then Friday night, we should be posting grades, I would think. Also, the 25th, that would be Sunday, right? The 25th, we will turn homework grades back off, and it will go back to just KGA items again. Okay.
Are you able to put in there the what ifs? I know like other classes, you can do your what ifs grade.
You can do that. I cannot.
No, it's something on your end or somebody else's end where it has like the exam 1, 2, 3. It just doesn't have a grade yet, but you can toggle with it and put your what if grade in. We are the only class that doesn't have that ability.
Oh, no, my understanding is that if you as a student want to use that what if tool, you can, but I can't do anything with it.
We don't have it. It's like we only see exam 1. Like yesterday, we could only see
Our
exam 1.
exams didn't even like come up. Like the
Yeah.
slot for our exam didn't even show in our grades until after our grades were posted. I think what
Yeah,
she is
like-
saying is that like we don't even have like it in there to see. Like we don't
Yeah.
have any of the exams, any of the quizzes, anything like to put in our grades. Be able to see what we need. If that makes sense. I can send you a picture if you need it.
I will ask our team leader if there's something else I can do differently. But she helped me set it up, so I don't know.
Like other teachers have it. I know it's really simple to do. We asked our dean to do it, and she literally did it within 5 minutes. So I think it's just like you hit a button and it appears. So
okay, I will ask her how to do that. You know, on the syllabus, all of that information is there, right? As far as what is that what you're looking at? Is what percentages each exam is?
No,
like
so
you
can put in, like, say this one is on there. It'll say like a dash, a slash, and 100. I can literally put 0 to 100 in there and click off of it, and it shows me my what if grade if I get that certain amount.
It basically tells you what you need to make to pass.
Yeah, but we don't have that. We don't have that.
Okay, I will talk to her and see what I can do.
Okay.
But are you talking about people who are in other online OB classes have that, or just other classes?
Other OB classes, yes.
Okay. I will talk to her.
All of our classes ever have had that, but yeah, the OB classes as well.
Okay. I will talk to her because she's the one who helped me set it up, and she's the team leader. So maybe we just missed it, something she didn't show me, but we'll find out.
Appreciate it.
Right. Oh, you're welcome. I'm glad you brought it up. We'll see what we can do.
Thank you.
You're welcome. You guys have a great week. I will see you next week. It'll be a while. Bye.
Bye. Thank you.
Uh-huh.